Well, ladies and gentlemen, if we can reconvene. This final session on elder abuse is an opportunity for me to introduce you to the 3 different research teams that I work with in this area of elder abuse. So these are 3 different kinds of presentations that I think you will find interesting. So this first one, these are my co-researchers. And we want to give you a little bit of background. LGBT people have long experienced trauma, isolation, stigma, discrimination. They're less likely than their heterosexual age mates to have partners, to have children, and if they have children, to have children who are supportive. These characteristics make them potentially more vulnerable than other older adults to elder abuse. But the key question in both the practitioner community, the real people living in this community, and researchers is, what is the real situation? We've been lacking data up to now. So the thing is that in addition to having socio-demographic characteristics that fit with risk factors for elder abuse, within the LGBT community, they have some additional kinds of risk factors, such as the threat of being outed, which is somebody disclosing their sexual orientation or gender identity without their consent. And you will hear more about this as we describe some of the other projects. This work is looking at data from the longitudinal study on aging through a SOGI, which is the acronym for sexual orientation and gender identity, looking with that lens. So study number 1 looked at the prevalence rates and risk factors for elder abuse types. And CLSA only looks at 3 of the 5 recognized types, looks at psychological, physical, and financial abuse. And we looked at it comparing heterosexual individuals with those from the LGBT community. In study number 2, the focus is on perpetrators. And there were 2 additional studies that we did during the COVID pandemic because CLSA had a special survey that they did during the pandemic. So that's my later presentation. In this one, we're going to talk about study 1 and 2. So you've heard quite a bit about CLSA. Our data is presented in a variety of ways, but at the population level. And this just gives you a timeline that CLSA had some people who were only interviewed by telephone, and other people who were interviewed in person, and where there were biological data collected as well. But this is the timeline. The elder abuse module was only introduced in the first follow-up. So, and it will be reintroduced, or it is being introduced now, 6 years later, in the 3rd iteration. In the second follow-up, the focus was on intimate partner violence, and we have that data, but that'll be next year's presentation. So just to look at that timeline, the recruitment started in 2011. Follow-up 1 was in 2015. and follow-up 3 will end in December of 24. And that's, you see, where the COVID one comes in. So the elder abuse module is modeled on what was developed by the National Initiative for Care of the Elderly and used in the National Elder Abuse Survey conducted in 2015. So there have only been 2 Canadian national studies of elder abuse. And the last one was 2015. So this is brand new data. And the elder abuse module has 4 questions on psychological abuse, 6 questions on physical abuse, and 3 on financial abuse. And this shows you what the questions look like. So the module of elder abuse was only administered to people who were 65 and over at follow-up. So that gives us a population sample of 23,000. And this gives you the eligibility of people. They had to be cognitively and physically able to participate. We have a manuscript that has been accepted by LGBT Health, which is a very high-profile journal within the LGBT research community. So the overall prevalence rate was 10% for heterosexual and 12% for LGBT. And we had a very small sample of trans, so those people were mixed, put where they, in the group that was their gender identity, their current gender identity. But what we see here is something that really leaps out and again was not foreseen or not talked about before. But when you look at that comparison, we see that the highest prevalence rates for any type of abuse was in the lesbian and bisexual women. If we look at psychological abuse, classically, the psychological and financial are the 2 most common types of abuse. And here, the overall prevalence was 8.8%, but again, what we see is very high rates, relatively speaking, amongst the lesbian and bisexual women. The prevalence of psychological is 8.8. What you will see in the next 2 slides is that the prevalence of financial and physical abuse was much lower, actually 1.3%. Again, lesbian and bisexual women had the highest rates, but then we see something different in physical abuse. Here it's the men, the gay men, who had the highest prevalence rates. So the importance of this study is it's amongst the first to determine prevalence of elder abuse among LGBT older adults in Canada. And I can say, probably we have more data than anywhere else in the world at this moment looking at this particular marginalized group. What the findings suggest is that there's divergent risk across the LBG gender and sexual orientation by type. And we found differences between the bivariate analysis and the multivariate regressions, that may well highlight individuals' intersectionality, because what we found in the bivariate was a significant effect for sexual orientation, for SOGI. But when we went to the more sophisticated analysis, where we compared and put in different or all of the socio-demographic variables, it no longer was significant. And if you look at the posters on the way out, you will see the posters that are from one of our other projects make it very clear that people who are part of the LGBT community are also part of a lot of other communities. And so, as with any of us, we wear many hats. So our sexual orientation, our gender orientation is one part of us. We also have education, we have religion, we have personality, we have a lot of different things. And it may well be that some of the other variables are actually stronger when it comes to the predictors of abuse within this community. In study 2, we were looking at the perpetrators. And what we found was that there are different patterns depending on which of the SOGI groups. So what you see on this slide is in the case of lesbian and bisexual women, the perpetrator was most likely to be another family member, mostly female, and someone who didn't live with them. If you look at the heterosexual men, the partner was most likely to be the perpetrator, and of course was more often somebody who lived with the victim. So when you start to look at some of these other variables, and Andrew was talking about silos, sometimes within research we do it in silos and we look at one variable at a time. It's so important to look at more than one variable and to recognize that the different types of abuse may well have different patterns. And what leaps out in these slides are the substantial number of people where the perpetrator was not a family member. And in elder abuse, particularly psychological, most of the literature has talked about the perpetrators being family members. But what we see, particularly in the gay men, and again, the lesbian women, but most prominent in the gay men, those brown bars, and that's other. So we're starting to see that people who are defining, and this is people within the survey who don't name the person, but they name a category of persons. And we actually looked at the written response of who might this be. And what real people are defining as abuse is much broader than some of the classical definitions. So, I mean, we had a bit of a giggle on noticing that some of the people had said that financial abuse, they named the Canada Revenue Agency. You know, and so you have to sort of look at this much more broadly than the traditional kinds of things. Also, you know, another example would be people were saying that they were ripped off by a landlord, right? So it's a phenomenon. We are so lucky to have the CLSA. It's really a national treasure. So I'll just flip through these really quickly. And this is the conclusion. And like all studies, there are limitations. One of them is that there will be six years between the two abuse modules. But the CLSA gives us a chance to look at incidence as well as prevalence. So to see if there are some people who become victims that were not victims in the earlier rounds, and also to be able to, we can look at multi-victimization. We have seen that there are about 20% of the people who were victims of one type of abuse or another where it was more than one. The vast majority of people are only abused by one perpetrator, but about 20% have more than one perpetrator. So we would like to acknowledge the CLSA for releasing data to us, and to acknowledge CREA, the Council to Reduce Elder Abuse from the province of BC, who gave us a grant that enabled us to do this analysis. Thank you. Okay.
Yes, thank you. To advance, okay. Hi, I'm Jen Marchbank. I'm reporting on the next project. So most of you will know Gloria as a very, very excellent quantitative person, but she also is involved in our qualitative work as well. So Gloria has given you the numbers. Claire and I are going to give you a little bit of a taste of a project that we have just recently completed, and you should see our self-promotion flyers on every table. This publication came out of the Indigo Survivors Project. Just like to acknowledge that we are here today on unceded Indigenous territories. So this project has also used the same categories of elder abuse from NICE as Gloria has already explained. And we did particularly look and recruit persons over 55 who self-declared that they had experienced one of these categories or more. Importantly, as a self-identified LGBTQ or gender and sexual minority elder. So this is not about what I experienced, the homophobia I experienced at 25. This is about what I've experienced as a self-identified 2S LGBTQ elder. But Claire is going to give you more of the details of that, but I just want to give you some background on where this comes from. This team here, I think it's been like since 2015 or something, we had an intergenerational project in the past that started this work for us as this particular team. And that work was funded by the BC Council to Reduce Elder Abuse. And it was led by Gloria, of course. This was Queer Youth. That's a youth group my wife and I run called Youth for a Change, which is Surrey-based, which is young people 13 to 21. And a group that Claire was very much involved with called the Quirkies, which is the Queer Imaging and Writing Collective for Elders. They worked together throughout, I think the youngest was 16 and how old would 84 for Pat, yeah, so there's the age range. Really unique intergenerational projects. A lot of intergenerational projects are young adults interviewing older adults, and then the young adults take the data away and do something with it. This was truly entwined. The silos were removed. The age silos had gone. They worked through weeks and weeks and weeks, guided by our artistic director, Dr. Kelsey Blair. Produced 5 fact sheets and 3 digital videos. The fact sheets are available in, I think, standard Chinese and Punjabi, as well as English. They're free to download on Gloria's website. So they are also on the poster boards, yes. The 3 videos are trans women in residential care, financial abuse by a younger man to his older partner, and then physical violence. Then Gloria took one youth and one older adult from the project with her to every health authority in BC, where the youth and the older adult were actually seen as agents and experts and the public speakers, which is quite a different experience. Gloria and Claire did lots and lots of radio interviews. We worked with the Seniors Advocate of BC. We did things in different communities. So we did specialist town halls for those working with different ethnic groups in BC. So we got it out there. I took it to the UK. These materials ended up being part of the University of Plymouth's medical school sociology teaching that ended up in their code. And I'm taking this new project on the same tour next month. So Scotland gets a taste of this, and you wonder why. Okay, so here's just, if you haven't already seen the posters, this is a series of 5. And this is what Gloria was talking about intersectional. We wanted imagery. We followed the Zero Tolerance campaign of Edinburgh back in the 90s. So the imagery was not going to show a victim. It was going to show a gentle person with lots of different descriptions. The members of Quirky are the top 3 models. The financial abuse was a friend of a Quirky, and not really surprisingly, we could not get an older South Asian woman willing to be identified as a lesbian. This is the only time we had to go to stock photo. So there's your link. We said we'll post in the chat. Aha, this must have been a presentation from a Zoom. So I'm now going to, having given you the background there, what we didn't know when we started the Raising Awareness project was that we thought we'd create some specifically intergenerational materials. We thought the process of intergeneration was a unique aspect. A few weeks in, what we realized the really unique aspect was this had not been done in Canada before. So those materials we produced, that some teenagers and some elders produced, actually were Canada's first ever educational awareness raising materials on LGBTQ elder abuse. So that was a bit of a shocker, but we rolled with it. So now I'm going to hand over to Claire, who's going to talk about the Indigo survivors. If I don't fall off this platform.
Hi, everybody. Thanks, Jan. So the Indigo Survivors Project was a partnership, and I'll get into the reasons why in a moment. It was the same SFU team, Jen, Gloria, and myself, but we partnered with community. The acronym doesn't stand for anything. It's not actually an acronym, but it is a provincial organization that provides resources to GSM people actually across the province. Courtney Diekbreder is a specialist in seniors programming there, and she is the person who fields many, many phone calls from distressed elders in the queer community. We also engage the services of an very experienced trauma counselor, because we believe that we should not be garnering stories of abuse without supporting the participants. As the disability community has famously said, nothing about us without us. And this might be said to be the one of the guiding principles of the project, is that we wanted to actually get the lived experience of survivors. All the straws in the wind suggested to us that GSM people were more at risk, but nobody really had talked to them. There was one study at that point that did include a few quotations, but nobody had interviewed in depth the stories, the actual survivors. And of course, until Gloria's fabulous longitudinal study, we didn't really know what the incidence was. We could guess that the situation was far worse for GSM people, but we didn't know that until recently. This project was funded by the Vancouver Foundation and New Horizons for Seniors. Community and the project team co-wrote those grants. So why? Why did we do it? What were our mission and outcomes? We wanted to advocate, obviously. We wanted to provide spaces for healing. We wanted to provide counseling and peer support. And we thought that an anthology of stories would be the best way to disseminate this material. At the time of my speaking, we're also looking into the idea of making a film because it would disseminate this material to different populations and to different ways. Jen has taken the lead on a knowledge synthesis, and we got a nice grant from Shirk to process that, and we are very grateful for their support. Community will be producing a report on elder abuse, and we also had and still have a wonderful student RA who has since undergraduated but got so caught up in the project that she has carried on helping out with it. She's looking to work with older adults. And we put her name on the book. How many 23-year-old undergrads get their name on a book with the fabulous Gloria and 2 other senior researchers? She's pretty thrilled. We did get together a group of community consultants. Recruitment was the huge issue in this project, finding participants who were willing to speak through the many layers of stigma and shame that surround this. It's one thing to be queer, it's another thing to be old, and it's altogether another thing to fess up to the fact that you have been ripped off or abused. So we assembled community consultants who have considerable agency and have built up trust in the queer community to help us partly with that and to keep us honest. Also in the loop, we had an interview with Isabel Mackenzie, and we had support from Spencer Chandra Herbert and Jenny Kwan. So I think Gloria has spoken already to why we need this project. We are more at risk for elder abuse. We're more likely to live alone, to be depressed, to have intersectional disabilities and illnesses, less contact with our families of origin, much more likely to have experienced trauma and to self-medicate, often through drug and alcohol abuse. And our relationship with the healthcare industry or organizations has not been great. The AIDS epidemic left us with a deep distrust of the healthcare system. This came through very strongly in the interviews. Unfortunately, medical teams still exhibit ignorance. This is supported by the literature. It's not just our sense of it. We're less likely to visit doctors, less likely to come out when we do visit doctors. A huge factor, and one of our biggest findings in the project, is the impact of systemic cultural violence for this population. My cohort of queer elders, I count myself in there, I'm 74 this year, we lived through a time when being gay was a crime, when being gay was an illness. Many of us lived in the closet. We couldn't marry, so our financial arrangements were often informal, and that has left us open to financial abuse. And importantly, we experienced constant slights and psychic woundings. And this is something I think that is not well understood by many in the heterosexual population. We weren't counted in the census. Gender identity was only added actually a couple of years ago, I think now. And this makes us more vulnerable to both tolerating and accepting high levels of abuse. We got ethics approval from SFU. Boy, was that was that a process. You know, when you're dealing with vulnerable populations, it becomes quite tricky. I think I had a page of notes that I had to read to each participant before the interview. It was quite daunting. A very detailed consent form and description of the project. Interview questions, of course, the interviews were semi-structured. I did all the interviews. I barely ended up using the questions. Frankly, the first interview was meant to be an intake interview where they could ask me questions. And I would say within 3 to 5 minutes, they were off and running, telling me about what happened. And they didn't really stop for an hour and a half. And I just kind of was sympathetic and said things like, did you have support at that time? There was no stopping them. It's the first time that their stories had been heard from start to finish. So what we offered, a chance to advocate for themselves and for others, free individual sessions with a very experienced trauma counselor, and a peer support run by community. Community have now made that a permanent project. If you go onto their website, you see it's now a permanent program. It was so successful. We had 9 participants. They shared stories concerning violence by partner, financial abuse, neglect and abuse in long-term care, and abuse by in-home care staff. I did all the interviews for consistency, and I had at least 2 interviews with all 9. What I did was we transcribed the first interviews, which were extremely lengthy, as I said, and then I turned those interview transcripts into tight first-person narratives. And the reason for this was that we wanted people to actually read the book, and interview transcripts are often not very engaging. But once I'd done a draft of the narratives, I then worked in further interviews with each of the participants to make sure that they represented them. A couple of the participants, one wrote her own account, very skilled writer, and another edited considerably. So our book will be published in June. As Jen said, you have the leaflets, you have the prospectus on your tables. It includes the 9 narratives from survivors, a summary of LGBTQ history, which Jen was responsible for, focused on cultural oppression and systemic violence, a lit review written by RA, Michaela, a description of the project methods, and a discussion at the end, which is basically what the 4 of us managed to conclude from the narratives. Here's our beautiful cover. So we end really by asking, you know, what does your organization need? Thanks for listening. We'll take questions at the end of the 3rd presentation. Thank you very much.
Turning now to COVID. For the past probably year, I've been monitoring the literature to see what the actual situation was as opposed to the doom and gloom that many of the experts had projected, including me, in the early days of COVID. You know, we all said, well, if you look at the disaster literature, you see there's always an increase in child abuse, there's an increase in spousal abuse, although there wasn't much data, or there still isn't much data around on abuse of older adults during disasters. We all predicted that it was going to be total doom and gloom, and you will have heard or seen some statistics tossed around. I have recently done a lit review, and it's still in the bits and pieces stage, but we pulled out something like 70 articles when we input as search terms elder abuse, LGBT, heterosexual, and disaster and COVID. And of those, there's only a small number that actually have new, real data. And we have one of our studies, in fact, looks at a proxy, because the actual elder abuse questions were not included in the special COVID study that CLSA did. So what we did was to, okay, that's our timeline again, to remind you. We had a dual prediction, because on the one hand, we thought, given their socio-demographic characteristics, it could be that it was really be tough, extra tough, for LGBT people during COVID. On the other hand, there was the possibility that when you're talking about older people, these people have lived through disasters before. In particular, they lived through the AIDS epidemic. And so we had thought to ourselves, it's possible that they may do better than other groups, given that they've had this experience. And in one of a different study than this one, where one of my other teams we did a national survey, what we found was compared to their heterosexual age mates, there were more in the LGBT community who took public health directives seriously and who wore masks, who socially isolated, and who did the things that one would expect them to do if they wanted to protect themselves. And we think it's you know, as best we can tell, it's because they already had some experience, they had some coping skills. So to test these competing hypotheses, we picked, there was one question in the survey that asked participants to essentially rate the consequences of the pandemic. And it was a 5-point scale. We collapsed it to 3 points, and the main variable was self-rated mental and general health, as well as sexual orientation. And what we see in this slide is that men were more likely to perceive the consequences of the pandemic as negative or very negative than women were. Heterosexuals would more often perceive the consequences as negative or very negative compared to our lesbian or gay or bisexual individuals. So that was the first surprise. The gay and bisexual men and lesbian bisexual women were least likely to perceive negative consequences. So, I mean, still about half of them did perceive negative consequences, but it was a lesser percentage, again, than the heterosexual women or heterosexual men. Not surprisingly, those who were who in the prior follow-up 1 cycle reported that they had fair or only poor general health or fair or poor mental health were more likely to say that the consequences of the pandemic were negative or very negative. And although overall the consequences were high, like I say, you know, half of our respondents said COVID did have negative consequences for them. Those with the lower self-rated mental health or self-rated general health and the LGBT people were less likely to say that their experience was negative. So that was, to some extent, good news for the LGBT community. In a second study, from using CLSA data, in this case, we were looking at, let's just see, some of the determinants, and what we found here was in the bivariate associations, there were a number of variables that led people to say that they had experienced increased verbal or physical conflict as a result of COVID and their experiences. And the yellow bars tell you the number of people who said yes, that they had experienced increased verbal or physical conflict. The good news is it's a relatively small percentage. The bad news is that for some groups, there was more of this experience than for others. And what we find is that in terms of living with another person or living alone, as one would expect, the rates were higher amongst those who were living with another person. There were small significant difference in terms of education, but race was not significant. And this was important because of the issue of multi-marginality. We were interested to know, are those who are LGBT and from an ethnic minority group, are they more likely to have had a bad experience? So this shows you some more of the characteristics. And what we do see here is that there was a significant difference with the LGBT respondents experiencing more of this conflict than their heterosexual peers. So in this case, we did find some evidence that, in fact, it was tougher for the group. So, but as I say, the important thing is that there's not much hard data. And as best I can see, amongst the most interesting of the hard data comes from agencies who work with people who are abused and who have some records. And that's why it's very exciting for me now to turn the microphone over to Marie Noel from the Seniors First BC, and she's going to tell us about the data that they have, which is actually, my data is only during COVID. I had no before data, they have before and after data.
Okay, thank you. All right, first of all, I wanted to say that this data is about abuse generally of older adults during COVID. So I'll briefly introduce you to our organization, Seniors First BC. Some of you may know it as the BC Center for Elder Advocacy and Support. It was established in 1994. We are a provincial charity that provides information, legal advocacy, and support to older adults and those who care for them and who want to relate issues that affect older adults. We have several programs. The main one is the Seniors Abuse and Information Line, also referred to as SAIL. And with me is Tina Cheng, who's the SAIL and Victim Services Manager, the second program on that list. We have an elder law clinic, a legal advocacy program. So these legal programs assist with anything from information, legal information, the preparation of legal documents, including advanced planning documents, so will, a representation agreement, a power of attorney. We assist people who go to court. And we have a public education and outreach program. We work with police agencies, health authorities, government, academic institutions, nonprofit organizations. What should be said again is that we're not an investigating or reporting agency. SAIL, the Seniors Abuse and Information Line, is available every day of the week, 8 a.m. to 8 p.m. on weekdays and 10 a.m. to 5:30 on weekends, and language interpretation, including indigenous languages and American Sign Language interpretation, is available during those times. And most of the data that I will present today is from SAIL. So this data is from 2019 to 2023. Initially, so you see initially during the start of the pandemic, just before the pandemic, there was a slight drop of calls. People didn't really know what was happening. And then it started rising. It dropped around September 2020, and that's mostly because, like many agencies, we had staffing issues. People who had to care for loved ones. And so we had issues answering the call and meeting demands. And the lines actually allowed for remote services. Around January 2020-21, we saw a spike of calls at that time. And since then, calls have increased slowly, but steadily. So we had 5,450 calls in 2019 to 2022, and now in the last fiscal year, we had over 1,000 more, and that's all over the province. In terms of abuse-related calls, though, they have steadily increased, except during that period between September and January, where we had technical issues answering the phone. So what we saw was that when the pandemic was declared as a global health emergency, older adults themselves had difficulty calling and were not calling as often, but most calls came for third parties, affected third parties, who were calling on behalf of older adults that they were worried about. We believe that it is because the older adults themselves, as relayed by the third parties who called, were experiencing abuse and they didn't have a safe space to call us. So when it came to the type of harms related during those periods, emotional and physical and psychological harm came first. Closely after that was financial abuse, so that can be from relatives who steal from their loved ones, who can use or misuse a power of attorney to access the funds of an older adult, or who can pressure them for money or shelter. Then is neglect, physical abuse, self-neglect, medication-related abuse. We saw that a lot in healthcare facilities, sexual abuse, and spiritual or religious abuse. So when we look at the variances and what is clearly apparent is that self-neglect was on the rise, and that is due to isolation. We heard about self-neglect usually from loved ones who witnessed it either when they came to visit a parent or a sibling, or when they came to a long-term care facility or an assisted living facility after the social distancing rules came into effect, and they would notice that food in the fridge was rotten, the sheets were not washed as often as they should have been, or they were clearly indicators of lack of appropriate care in those facilities. And that's also because there was a shortage in caregivers. There was also a large amount of calls related to, for emotional abuse during the COVID peaks, particularly during confinement and when vaccines were not available. And we noticed that physical abuse increased by 54% compared to before COVID. In terms of the demographics, I specifically asked for information on LGBTQ-related older adults, and we didn't have sufficient data. So we had actually less than 5 calls in 2019-2022 from people who self-identified as member of the LGBTQ community. Part of it is also because when people tell us that they are female or they self-identify as female or as male, we don't ask for the history of it. We don't ask what sex were you assigned at birth. So if someone tells us, I self-identify as female, they might be queer, they might be trans female, but we don't ask more questions, we go by what they tell us. Another issue is that what we're hearing from friends and community partners is that they may not feel safe enough to come to us and prefer to reach directly to community or a group who is part of the LGBTQ community because they know that people will understand their issues. We have hired over the last 2 years several staff members who identify as queer or lesbian, and we're trying to make progress to ensure that we have dedicated outreach to the LGBTQ community, and we're actually about to start a partnership with community. So I just wanted to say that. It's not that we don't think that LGBTQ and to us, two-spirited people should not appear on those statistics, is that we don't have sufficient data to talk about what happens specifically to them. So when we look at the type of inquirer, so that's the caller, you'll see the trend, so that's the top right part of the graph. We see that there was mainly, so it's mainly the affected individual who calls, but second was an affected third party. And initially during the pandemic, the affected individuals, so it was only 55% of them who called, but they decreased a bit. Sorry, it was only an affected third party, like 32% of the time at the beginning, and then it increased slightly because they were more and more concerned about their loved ones. And then it was a service provider, so often from a healthcare facility or another nonprofit organization who didn't know how to deal with an older adult who was abused. And we tried to provide them, tips or encourage them to have the older adult reach out to us directly. And in most cases, older adults who reached out to us lived independently, and then they lived in long-term care. In terms of the demographics of the alleged abuser, like we saw, it's usually a family member who was abusing the older adult. Next is typically a healthcare professional. Then it's a friend or a neighbor. And then a lot of housing issues. So we heard a lot of people talking about issues coming from their landlords who either had very strict rules about masks, people saying that they had to wear masks in the hallway, or that they had health issues that prevented them from wearing a mask, or mental health issues, people who were claustrophobic, people who were having breathing issues that prevented them from wearing a mask, and they couldn't abide by the restrictions. And because of that, they felt that they couldn't get out, that they couldn't go to the hallway because they were afraid that they would be served with an eviction notice. Other issues we often heard about when it came to housing issues were older adults who were prevented from housing their children. During the pandemic, there were a number of other issues that happened, including financial issues. There were heat waves, and landlords put a lot of restrictions on older adults. Mental health issues were on the rise as well during the pandemic because social isolation affected everyone. And so when we look at the data on older adults, we also have to look at the data for the rest of the population, because when the children of the older adults are at risk and have mental health issues, it's going to affect the parents. It's going to affect the parents because they're going to ask them for money. They're going to ask them for shelter. And it's very difficult for a parent to say no to their child when they need shelter. They say, no, I cannot let you sleep on the couch because I'm going to be evicted by my landlord. And these issues we saw quite often. We heard about an older adult who let their son access their garage, and they had been served with an eviction notice because of that. That is quite common, and I'm seeing that today quite often still as part of our tenancy program. So here's another example, an older adult who called Sale, who was seeking a place to talk due to isolation arising from the pandemic. She was also experiencing mental health issues because of that isolation. She had health issues as well, and she asked her landlord if she could remove the carpet. There was a doctor's note saying, I cannot have carpet, I have allergies, it makes me more sick, please help. The landlord refused. The landlord said, if you want to move, here's a note on how to get new housing through BC Housing. But we know that to get a new place through BC Housing, it can take 18 months, it can take 5 years at times. So you're not going to find housing the next day or the next month or in 3 months. So that meant that the older adult was stuck and preferred to not say anything because she knew that she would not be able to find a safe place, and therefore, there was no solution available for her. When it came to those housing issues, we saw them as well in the assisted living and long-term care facilities. Whenever an older adult was experiencing lack of proper care, the family members felt that they could not do much. I mean, we talked to them about, how to navigate those issues, and we are actually in the process of publishing a wiki book on how to navigate issues in assisted living and long-term care facilities. The problem that we see is that most of the time there's nowhere else to go. Most of those facilities are at capacity, and people are afraid of calling for help or reporting the issue because they are afraid of repercussions. If you have an older parent who's in the long-term care facility and who is being neglected by that facility, well, if you complain about it, are you going to be able to protect your parent or your brother or sister from any repercussions, at night? Some of those callers told us, my mother is not getting enough water at night, and I'm afraid of saying anything because what if they cut her food next? And so we talk to them about the various issues. We decide also what we can do for them, what other supports are available. But those issues that we saw during the pandemic are still issues today. Anyway, thank you.
We really wanted you to see some of the complexity in this area, and both from the point of view of what happens to real people and also in trying to work with the data. So when you look at agency data, you want to ask the question was there an increase in general in calls, which there was, or was there an increase in abuse calls, which there was? So, but they're two different things. So some people would phone up and as you said, you're asking questions about housing and about other things when they call into an agency. So I know it's late in the day and people are tired. Do you have any burning questions you would like to address to our distinguished panelists?
It is on the abuse, on the medical professionals side of it, and specifically I was wondering about GPs, because many seniors have the GPs retired, so they have new GPs, they're lucky to find new GPs. And they also know that it's so difficult to find a GP, and they are lucky if they could find one replacement GP. But then particularly during the pandemics, I heard many stories about seniors felt the dialogue with the GPs in the past disappear with the new GP, usually are younger people who may not understand the issues the seniors are facing. And so those dialogues disappear, and so it replaced by more abusive way of verbal abuse about instructional or ignoring seniors about what they need, and just tell them what they should do or not to do. And so they're afraid to confront and talk to the doctors because they were afraid that they will lose the GP. And some GP did threaten the senior that if you continue to do this, I will fire you. And also an extreme case about a senior would say, I couldn't stand it, I have to live without a GP rather than go with a GP. And so the talk about it is, it's a distinction between a professional misconduct or abuse. I couldn't distinguish the two, and I'd like to hear what you view, or whether we came across this kind of, not just a medical professional, but the GP side of it. And I don't know whether it's a dumb question.
And I'm going to add to that, one of the reasons that dialogue couldn't happen wasn't just that GPs changed, but many GPs refused to see people in person. And then you've got multiple barriers if you're senior, or if you're, especially if you're LGBTQ, if you have to have someone else in your care home or whatever, moderate your Zoom meeting with your GP or any healthcare, that's a barrier for you to be honest and open in what you're telling. So I think that telehealth at the very beginning was a barrier for many who didn't have the technical support.
That's it? Okay. Yeah, what we saw generally wasn't just an issue with GPs, but an issue of being denied care and relatives coming to us because of wrongful death. Technology, like you said, was an issue because not only there's the issue of accessibility, you know, issue of being able to connect to the internet. And again, not everyone in BC has a reliable internet connection. Whenever we go on reserve, most people on reserve do not have a stable internet connection. And that means that most First Nations on reserve were denied care if they had to access it through Zoom. Many of the people we serve have hearing issues or vision issues, which again is an additional barrier to access care. So what we saw was not specific to accessing their family doctor, but just getting a doctor to see them.
I think what also came through our interviews was that when the healthcare system is under stress, undue power is given to less well-trained healthcare professionals. So in our residential care, we had 2 of our participants who were abused in residential care. And that was often because the nurses and the doctors were so greatly overworked that they relied upon nursing aides and less well-trained healthcare professionals, and they didn't want to upset them. So, one of our participants said that really the aides kind of ran the place, and the nurses didn't want to upset them because they wouldn't get support. And often these are the very people who haven't had sensitivity training. Some, obviously not all, are from fundamentalist Christian backgrounds or cultures in which there's not a great deal of awareness of LGBTQ special needs.
And that's not just during COVID.
Yeah. And the same with in-home care providers. I mean, we, just to cite one example, we had one trans woman whose in-home care help said how much she and her friend liked to travel around to go to gay enclaves and gay pride events so they could mock and ridicule gay people. That was one of their favorite pastimes.
I'd just like to take this opportunity, because some of you may be sitting there going, well, what did we actually find out? And what is the difference between abuse experienced by heterosexual people and abuse experienced by 2S LGBTQ? And our findings were a lot of it's the same. But we also found where it's different. And Claire mentioned that in the presentation, that long line, that long history of systemic violence. And it was mentioned by Louisa May Coo yesterday, the evolution of events that shaped aging lives. So it's that we had cases of internalized homophobia so strong that it led to absolute self-neglect. Someone who would not come out at all to the caregivers who were going into the home because she wouldn't even say the word lesbian herself. The mismatch of cultural competency. So with that case, the organization that was trying to care for her tried to be culturally competent and say, well, we'll match you with a social worker from your cultural group. That cultural group happened to be from the Mediterranean, a very heterosexual, very patriarchal culture. So it silenced this woman yet another layer. And I think this is what we're looking for, whether it's LGBTQ folks or heterosexual folks. There are so many barriers in this area of elder abuse that we have to be intersectional and culturally competent in more ways than one.
Just one question. Thank you, first of all, for such an important study. I think that we need to strengthen LGBTQ2S studies overall, but especially for older adults. Even though we live in North America, we still see threats against people and trans and queer folks. So I think the policies and practices are very crucial, and how we can all embed it in our practices. My question is actually, I'm really curious, in one of the slides there was that we experience constant slights and psychic wounding, and I was really curious about what that is.
Yes, thank you for the question, which is a really great one, I think. I think when people think about homophobia and transphobia, if you are not yourself, if you don't identify as queer in some way, you imagine that that's going to be very overt and very in your face and very easy to recognize. But of course it's not. There are so many ways in which queer identity is marginalized in the media and in everyday life. And also in the 21st century, it's very unlikely that an in-home care provider or a doctor or another healthcare professional is actually going to come out and say that they are homophobic and transphobic. So something that ran through the narratives was a gut sense by the participants that, in one case, one of our gay male participants had to call the cops because his partner, his husband, had sent really very serious death threats that resulted in a police criminal case at a later date. But the first time he called the police, they were extremely casual and just said, well, obviously you boys have got some issues, you need to work it out, and it wasn't taken seriously. And he said, if I'd been a woman and my husband had been doing this, you can bet they would have taken it more seriously. But of course, the police didn't say anything overt. So one of our biggest findings, I think, was the way that covert, underground homophobia and transphobia are at play, but you can't really put your finger on it. You can't really name it. And also, as Jen said, the way that internalized homophobia and transphobia is at work. And these things add up over a lifetime. What we found is a lot of our participants, in fact, all of them, had been abused really throughout their lives. And that is a fact of LGBTQ experience, that we have experienced abuse in various forms throughout our life. And it's almost like a form of grooming, if you like, for abuse in adulthood and in old age. A lot of participants said, well, we're kind of used to it, we've learned to live with it, and we are much less likely to protest or even think of it as abusive.
I'd like to just add to that as well, is that we mustn't silo out this idea that there are seniors, there are LGBTQ seniors, and then there are abusers. Because we had at least one participant who was abused by other lesbians, financially, materially. And there's another layer. I can't speak up about that. There are many reasons people don't speak up about abuse, but here's a further one. People already look down on the lesbian community. Let's not wash our dirty linen in public kind of idea. But also, the other day, I was at a seniors event in Surrey, promoting a seniors program that I'm running in Surrey called the Rainbow Seniors Program. And an attendee at that, a woman looking to be in her 80s, wandered past, saw my signage, muttered under her breath, "Rainbows belong to God, give the rainbows back to God." My colleague from another organization who was sitting there said, "Did you just hear that?" I said, "Oh yeah, just because she's old doesn't mean she's not homophobic." So you have to think about the relationships within long-term care homes, where it's maybe not just the staff that needs some awareness raising, it's also So it's a British case I know of, but in one British case, and this is not one of our participants, but there was a case in Britain a couple of years ago where an older lesbian was visited by her son, who started to talk about his other mum, overheard by the participants, and that woman was physically hit by other residents. Because, like Claire said, we may have grown up in a time where it was illegal, and so did our peers. So just because someone's got old doesn't mean they're become aware of not being homophobic or transphobic.
Yeah. Well, I used to say to my students, you know, sometimes it's a diagnostic sign when a person who has always been nice becomes nasty, or a person who is always nasty becomes nice. Just because you get old doesn't mean you become nice. So on that note, please join me in thanking our panel.